Hey, everybody, if you're joining us early, we're going to give it a couple minutes before we get things kicked off here shortly. Thanks for your patience. All right, looks like the number of participants has plateaued there, so we're going to kick things off. Welcome, everybody, and thanks for joining us on our 17th episode of Ewings U. For those of you that don't know me, I'm Piero Spada, and I'll be your host today. I'm also co-founder at Little Warrior Foundation, and more importantly, father to 13-year-old Little Warrior Lucy. You're part of our core contingency, aka the Little Warrior Fight Club. Thanks for being here with us since day one and making this a place for positive change. And if you're new, well, welcome to Ewings U. It's our webinar series where we hear from leading sarcoma experts and discuss the cutting edge of care and science behind Ewing sarcoma. Today, we'll be hearing from one prominent expert in the field, pediatric radiation oncologist, Dr. Matthew Ladra, discuss the use of proton radiation in pediatric sarcomas. Briefly, Dr. Ladra has an MD and MPH, is the director of the Pediatric Radiation Oncology Program, the Johns Hopkins Kimmel Cancer Center at Sibley Memorial Hospital, a clinical collaboration between Children's National Medical Center and the Johns Hopkins Sidney Kimmel Cancer Center. Dr. Ladra also serves as an associate professor in the Department of Radiation Oncology and Molecular Radiation Sciences at Johns Hopkins University School of Medicine. Dr. Ladra earned both his medical degree and master's in public health at Tulane University. He completed a residency at the University of Washington Medical Center, followed by a fellowship in pediatric proton therapy at Mass General Hospital. Dr. Ladra also completed a year-long research fellowship in conjunction with St. Jude's Children's Research Hospital, studying and treating pediatric leukemia in Morocco. Prior to joining Johns Hopkins, Dr. Ladra served as the director of pediatric radiation oncology at the Provision Center for Proton Therapy. But before we kick things off with Dr. Ladra, just a quick reminder that Ewings U is a webinar production of the Little Warrior Foundation. We are a national childhood cancer foundation with a laser focus on finding a complete and permanent cure for Ewing sarcoma. We were founded in April of 2020 and have now granted out $1.6 million in high potential therapies for increasing survivorship and decreasing toxicity. And in order for us at Little Warrior Foundation to make programs like this a reality, we rely on the support of the little and big warrior community alike. We appreciate all of your support so that we can continue our mission of bulldozing our way towards more effective and less toxic therapies and continue this vital work for kids battling Ewing sarcoma. With that, I'm going to hand it off to my co-host, Emily, to introduce herself and touch on a couple of housekeeping items.
Great, thanks, Piero. I'm Emily McFadden, one of the co-founders of the Little Warrior Foundation and godmother to Little Warrior Lucy. Today we will leave lots of time for questions. Please use the Q&A functionality built into Zoom to ask those questions. We will save them for the end, and Piero and I will try to make sure we can get as many of your questions fielded as possible. Also, as a reminder, we cannot discuss any specific cases or provide direct medical advice in the context of this webinar. With that, we will hand it off to Dr. Ladra to get us started.
All right. Well, thank you so much for having me. It is really nice to be here and get to talk about things that I think are interesting and hopefully that you guys will find interesting too. We're going to jump around a lot today and kind of cover some of the proton therapy stuff and then hopefully some topics of interest. So some proton therapy, some review from some of the more recent children's oncology group studies relating to radiation, and then discuss some research that we have done at Hopkins looking at metastatic Ewing sarcoma and other sarcomas that had some very promising results. when I did my fellowship at in Boston at the Proton Center, I was really lucky to work with Dr. Herman Soot, who is the father of modern proton therapy, and he had two quotes that really summed up the benefit of proton therapy that have really carried on. That are one, there's no advantage whatsoever to irradiating uninvolved healthy tissue, and the second being, direct radiation complications never occur in unirradiated tissues. And that's really, I mean, it seems like a simple statement, but it actually is very profound in that the benefit of radiation is really the fact that when you don't give excess radiation to normal tissue, patients will not have any problems in those regions. So just to give you a little bit of background, we use a variety of different radiation particles. The most common and classic or conventional radiation would be photons or X-rays. They have no charge, they're very light particles. And they, when you shoot them at a target area, they get absorbed, and then about 30 to 40% of them kind of move out the back. And I'll talk about this a little bit more, but you do get some unwanted dose deposition beyond your tumor that you're trying to treat, or organ that you're trying to protect. But this is the particle that they use in things like IMRT, VMAT, CyberKnife, Gamma Knife, things that you may have heard of if you're familiar with radiation. That is the particle that all those machines use. Electrons are something we very rarely use in Ewing sarcoma, but it may pop up. They are very light charged particles, and they don't absorb very deeply. So if you have a basal cell carcinoma on your nose, sometimes we'll use electrons to do that, or some type of skin lesion. Today, we're going to spend most of our time focusing on protons. These are 2,000 times more massive than X-rays. They have a positive charge, obviously, and mass, but they have a very defined range, meaning they lose their energy very quickly and they stop very quickly. And they are more sensitive to density changes. So while they are good at stopping really abruptly, they're also very finicky in that if certain conditions change, they don't always stop where you want them to. So that is a blessing and a curse. So why doesn't everyone have protons? So as you may know, protons are sort of a rare resource. And when I started my training about 12 years ago, there were only like 3 in the United States. Now there's upwards of 45 centers, but it's taken a while for the technology to really become widespread because it is very complicated. So if this is the treatment table where you're treated on, to generate this treatment table, behind the wall here, there is a giant room here where there's an arm spinning and spitting out protons, and then there's a cyclotron which generates the protons, a beamline which used to require like a football field size of magnets accelerating it to the right speed, and then spitting them out in different rooms. So the proton center that we have at Johns Hopkins, it costs $160 million to build, whereas if we wanted just a conventional radiation machine, it would have cost a few $1,000,000. So it is very expensive and it's very complicated, and that's why it's not found everywhere. Just to talk about a little bit about how we deliver radiation with the current modern proton machines. I'm not going to bore you with how we used to do it back when I started my training, but in its modern iteration, we have this really nice, it's called pencil beam scanning. And basically you take a beam of protons the size of about a pencil or a crayon, and you deflect it using magnets in the X and Y direction, and you can sort of paint tumor layers starting from sort of the back forward, almost like you're painting slices of bread. And then when you're done with the layer, you sort of drop the energy of the protons, and then you do another layer. And it kind of looks like this. Basically, the beam moves back and forth, and where it dwells longer, you deposit more proton radiation, and so you get a higher dose. So this allows us to create really intricate shapes that we used to not be able to do. This allows us to be more conformal in what we're treating, so that we're not capturing, excess, or we're not depositing radiation into tissue that we don't want tissue to go into. So we can create these really conformal shapes and protect the normal tissue. So what is the advantage of proton therapy? Well, really, I think this picture on the right really kind of sums it up. So you can see that This one is with the conventional, and this is like VMAT or IMRT. You can basically treat, if this is the tumor, the same volume using proton therapy or photon therapy. And for, from about 100% to 70% of the dose, it looks basically the same. The difference is that because these particles are much heavier and positively charged, they stop, they don't go any farther, whereas these light X-rays, or photons kind of bounce out the back. And basically you get a lot of excess radiation to tissue that you don't want. It is a very low dose. So in adults, there's a question of whether or not this really matters. But in kids who are very sensitive, we know that sparing as much normal tissue from any excess radiation makes a big difference. And we can talk a little bit about that later. This is what it looks like if you're a physics person and you're looking at a single proton beam. It has a lower entrance dose. When you get to where the tumor is at depth, it deposits all its energy, and then you don't see any exit dose. With photons, it actually deposits most of its energy very superficially in the tissue, and then it kind of, that dose falls off. But by the time you create enough proton beams to kind of cover this tumor with Bragg peaks that are spread out over this area, and by the time you get enough photon beams to cover the whole tumor, basically this entrance area is kind of a wash, and it's this exit dose where the difference is. And again, it's a lot easier to sort of understand exit dose when you look at it as the difference between this picture and this picture. So how much is that difference? So this was a study I did when I was a fellow and had lots of time to play around before I had to make money for a hospital. And we had at Mass General, we had a bunch of sarcomas, 54 to be exact, that had been treated with protons over the last 10 years. And so what I did is I replanned them with the best, most advanced photon techniques that we had to see if I could come close to a proton plan with a photon plan. And what I found was that no matter how hard I tried, and no matter what site, whether it was in the head, in the neck, in the chest, in the abdomen, in the leg, protons always delivered less excess radiation. So it depended, the difference basically depended on where you were. And you can see here, these are the same cases side by side. So for this first case, the blue represents how much dose tissue outside of the target that you were trying to treat got with protons, and the red is with conventional radiation. And the difference varied depending on the site, depending on the size of the tumor, whether it was a central tumor or a peripheral tumor. But in all cases, proton wins in terms of delivering less excess radiation. And so when we sort of quantified that across 54 cases, the integral dose, which was the fractional energy deposited in non-tumor tissue, was 2 times higher on average. For head and neck, it was a little less than 2. It was about 2 for sort of bladder, prostate, and extremity, and about 3.5 times higher for things in the head and neck. So, we felt that we could definitively show that protons always deliver less radiation. Now, the question is, does that matter? And that's really where the debate arises. So there's no question that protons deliver excess radiation. The question is, in 10 years, in 20 years, are the patients we treating with proton therapy going to, are we going to know, is someone going to know that they were treated with protons because they're going to do better than someone who was treated with photons? And the answer is not always. So if you think about the benefit of proton therapy, if we're treating a sarcoma, Ewings sarcoma, we are treating, actually, I'll take a step back. So what does the elimination of low moderate radiation do for us? So, it's that exit dose that we talked about. This is what it looks like in the brain. This is what it looks like in a pelvic plan. So what are we looking to reduce? In terms of toxicity, we're looking to reduce to organs that are sensitive to this low moderate dose of radiation. We're trying to touch less normal tissue with radiation, which hopefully reduces the chance of causing a second cancer related to radiation. And the important thing to note, I think really important, is that no matter what tumor type we've looked at, whether it's been in the brain, in leukemia, lymphoma, sarcoma, renal tumors, whatever it is, protons and photons cure tumors at the same rate. So there's no difference in tumor control or outcomes with photons or protons. They do the exact same thing at the exact same rate. So they're just as effective at killing tumors. The thing that we're looking for is a reduction in toxicity. That's really the benefit of protons. And so when you think about what that is, so when we treat sarcomas, we're treating to doses between 50 and 70 gray. If I'm telling you that the only difference between protons and photons is this low to moderate dose radiation difference that we're seeing here in the brain and here in the pelvis, then to actually show a benefit in the long term, it needs to be organs that are sensitive to that, 50 to 30% of that dose. And so in the body, those things are the testes. So a lot of what protons can do is help reduce low dose spread into the testes or ovaries, which are sensitive to 2 or 6 gray, and preserve fertility. That's a huge plus of proton therapy. Also bones and soft tissue. So if you can spare going into taking a 10 or 20 gray into bones in the pelvis, into bones, in the scapula or whatever, when you're treating a chest wall tumor, that will eliminate the chance of having any growth deformities or any sort of hypoplasia or underdevelopment of muscle tumor in that area. Kidneys are very sensitive to radiation. So if you can treat here, pelvic tumor and not spread as much dose into the contralateral kidney there, you can make sure that this kid doesn't have to go on dialysis later on in life. In the heart, there's no safe dose of radiation. So every, gray or 2 increases the risk of having some type of heart disease. Usually it's coronary artery issues. Thyroid and breast are organs that we worry about developing cancers later on in life. And so again, no real safe dose. So all these things that we can basically spare from excess radiation in the long term probably do improve the quality of life for our pediatric patients. And, protons have been around since the 80s, but really there's been a proliferation in the last, 10 or 15 years. And so we're really starting to have good data showing that what I'm telling you actually does make a difference. 5, 10, 15 years down the road, our kids are doing better in these areas because of it. The caveat is that, one, you have to basically live long enough to benefit. So it's something that we typically don't do in palliative cases, although now that the cost is coming down, we are doing a little bit more of that. It's not as much of a scarce resource. So, but, to be able to see a benefit, we have to follow kids long, 10, 15 years out from treatment. And there are many cases where for certain things, photon radiation is equivalent. The classic radiation is just as good, and I will talk about that later. But why do we focus so much on kids? Well, this is probably fairly obvious to most of you, but children are much more sensitive to the effects of radiation. So their bones are still growing, their brains are still myelinating. Basically, the protective coating in the brain is still forming, and that happens all the way up until your early 20s. Your hormones are still doing all these important functions in your body, and we don't want to knock them out with low dose radiation. Obviously, fertility, your testes and ovaries are much more sensitive the younger you are to radiation. And the younger you are, the more sensitive you are to developing a second cancer, which I will touch on in a little bit. Like I said, proton therapy is exploding. This data is old. I think this data was published in 2019. There's not a newer study, but there's about 45 centers in the US. 23 of them treat kids, and we're treating over 1,200 kids a year in the US with protons. Europe has less, Asia has more centers, and these numbers are probably outdated, but this is probably more useful. That you can see since 2004, really the use of protons is exponentially increased, and in 2019, over 50% of patients with Ewing sarcoma were treated with proton therapy. Again, there's no sort of recent paper I was looking for, but I would say that that number is probably up to 80 or 90% at this point. And it's because we get these beautiful plans. So I don't know if you've ever looked at a radiation plan, but it's sort of a heat map in that where you see red, that's 100% of the dose. That's what we call a prescription dose, the dose we need to get rid of tumor cells. And as the colors get cooler, that's sort of at the dose fall off. And so, you know, a lot of times we'll see a bone tumor, you know, here for Ewing sarcoma. And so being able to treat with protons here, you can spare any significant dose to important organs like the bladder, the uterus here, the vagina. So really helping protect fertility. And I put this one in here because this was one of the first cases I ever treated when I was actually in Tennessee before I got to Hopkins 8 years ago, and she was 16. And even though she went through all this chemotherapy and radiation, she just had a baby. And so I was going back and reviewing this plan and you know, being able to basically protect the entire other side of her pelvis, protect that ovary, I think really contributed to that. And I don't think that would have happened with conventional radiation. This is another pelvic case. And again, just showing, you know, with small bowel bladder and ovaries and uterus here. With protons, you can really spare that, and you can't with other modalities. I collected a bunch of cases from other centers just to show, you know, what you do around the country. And this is a case from University of Florida. And again, they plan with their best photon case versus what they do with protons. And you see a big benefit in terms of, you know, the spread of low to moderate dose radiation. This is from the Mayo Clinic. This is how they do their pelvic Ewing sarcomas. And again, their photon plan actually here is a fairly nice photon plan, but still you can't beat you know, just the absence of any dose anywhere else in the pelvis with these protons. And this was from MD Anderson, a chest wall tumor. Again, you know, just eliminating any of this low dose tissue to the other kidney. There's no need for this kidney to get any radiation, this liver here. So that is really the benefit of protons. One of the things that we're working on that's sort of, I think, less common, and I'm not sure a lot of places are doing it, are proton whole lung radiation. So, you know, Ewing's is one of those odd cancers where, you know, if you have breast cancer or if you have colon cancer and you have metastatic disease in your lung, it's typically not curable. With Ewing sarcoma, it's still very curable if you have disease in your lungs, especially if it's not anywhere else and just in the lungs. And so we treat a lot of whole lung radiation. It's typically been done, it hasn't been done with protons. People think the uncertainty in the lungs and the beating of the heart would be too difficult. But with the help of Mayo, who has the same machine, Mayo Clinic, we worked with Hitachi to kind of come up with a strategy to do this. And we really use it for a specific type of patient, and it's older female patients who have enough breast tissue to spare. So again, I will get to this, but we really worry about second cancers in Ewing sarcoma patients and Hodgkin's patients, actually, because they get alkylating chemotherapy, which is a type of chemotherapy that can really help. I mean, it's very good at causing DNA damage in the tumors you want to get rid of, but it can also do that in normal tissue and lead to a cancer later on in life. And if you add radiation, that risk goes up. So breast and thyroid are two common areas where we see what we think are treatment-induced second cancers. So being able to spare any dose to the breast tissue is a huge benefit. So we've really pioneered a technique to eliminate any breast dose during our whole lung patients. It used to be that we just treat from the front, treat from the back, and the entire breast and thyroid would get full dose. With conventional radiation, with protons, we've been able really to reduce that. It does help spare the heart some too, although we can't completely eliminate the heart because this heart is beating and moving around in the chest as you breathe. But here's your thyroid. We're really able to spare that. So we think there's a huge benefit, and this is even someone with not a huge amount of breast tissue. So it's sort of a younger female patient. We wanted to see, you know, if there was still a benefit. And so we did our best proton plan and our best photon plan down here. And this is a heat map showing you the difference in dose. And basically all this extra green is about 20, is basically all the excess dose that comes from photons here. So it's still very early on in our experience. We're only about 5 years in, but we're really hoping that this is going to reduce even further the risk of breast cancer and thyroid cancer in our patients as they survive into adulthood. But let's talk a little bit more about second cancer risk. So obviously the scariest thing, if you've ever had to sit through a radiation consult, is when your doctors tell you that the treatment that they're giving you could actually cause a cancer later on in life. And when you look at older studies that were done 20, 30 years ago, looking at data that was done 20 or 30 years before that, they had this is secondary malignancy. So second cancer risk of greater than 10 or 15% or even 20% I've seen. That is an enormous number, saying that this treatment that we're going to give you, you have, every 1 in 10 or 1 in 5 kids are going to have a cancer attributed to that later in life. It was really awful to think that our treatments were doing that. The problem was this data was poorly curated. It was all done on, paper charts. They didn't have pictures of the radiation fields. They didn't account for whether, if you were treated in your arm and then you had, a breast cancer, they attributed that to radiation just because on a chart someone had said you had gotten radiation. They didn't really account whether it was in field or, something that just incidentally happened. And we also used a lot larger fields and more intense chemotherapy back then. So the good news is we actually have some really good modern data showing that the secondary cancer risk is less than what we thought it was. And so we looked at at Johns Hopkins, we looked at our 20-year experience of treating Ewing sarcoma. And this was before we had protons. This was all photon patients. And out of 94 patients that we could follow for almost 20 years, there were only 6 of them with second cancers. So 3 of those were leukemias related to chemotherapy, and 3 of them were solid tumors, 2 osteosarcoma and 1 synovial sarcoma in or adjacent to where these kids were treated with radiation. So that's about a 3% risk for a radiation-associated tumor and about a 6% risk for something lifetime. In terms of at 20 years. In terms of protons, so the University of Florida and Danny and Delicato, which is a great proton center that's been around for a long time. It was one of the big 3 many years ago. And they see a huge number of kids because they were before there were proton centers in England, all the NHS kids would come to Florida to get treated. So they have a vast experience, and after 20 years, they had only seen 3 second cancers, 2 leukemias, and 1 solid tumor related to radiation. So less than a 1% risk of a radiation-associated cancer. So obviously, I think, this seems extremely low. I think, I don't know if it's just a statistical anomaly or, I think it's closer to about 3%, but based on what we've seen in other centers, but it's definitely a lot lower than we think. And the reason I'm spending time talking about that is to talk about there may be a bigger role for radiation in Ewing sarcoma coming up. But before we get to that, I just quickly wanted to say, not all pediatric radiation cases benefit from protons, and a lot of Ewing's cases don't. So things where we're treating all of something like whole brain or whole lung, if you don't have breast tissue to spare, your whole abdomen, you don't want proton therapy. You want something that's going to leave a homogeneous dose across there. Extremity tumors. So for various reasons I won't get into, but if you have sort of a small diameter limb, sometimes photon radiation can actually do a better job of sort of carving out the areas that you want to treat with protons. Brain metastases, so things in the brain. Sometimes Ewing does go to the brain, and all of those we treat with conventional radiation because they are, well, that's not always true, but if they're small, we like to treat them with conventional radiation because we can get a higher dose, more of an ablative dose, and it's a lot more reliable in terms of where we can target these small tumors because the conventional radiation particles are not as sensitive to density changes as protons, and so we're much more certain for a small tumor that we're covering all of it. More common to Ewing sarcoma are lung metastases. So, the lung is a tough area to treat because a lot of times, even if you're doing breath hold, your lungs still move, and then you can't make your heart stop, so your heart's beating. So there is a lot of movement and density change in here, and using ablative doses with conventional radiation like CyberKnife or linear accelerator based what we call stereotactic body radiosurgery is a lot better than using proton. So for lung metastases, I always use conventional radiation because it does a nice job of this very conformal target, and it doesn't and I'm not worried about missing it because of density changes, which I am with protons. And same for small bone metastases, because the conventional radiation, we can sort of treat, try not to get in the weeds here, but basically for bone metastases, we can do a better job carving out the spinal cord here with conventional radiation. So for small bone metastases, things in the lung, which are things that often happen with Ewing sarcoma, I still only treat with conventional radiation because I think it does a better job and it's safer. Okay, but this is what I want to get to, a greater role for radiation. So I stole a lot of these slides from a children's oncology group presentation that Dr. Ahmed, who's a wonderful pediatric radiation oncologist at the Mayo Clinic, presented to us at the Children's Oncology Group, and that was an update of sort of the most recent Ewing's protocol that's closed now, but it was not so much looking at radiation, it was just looking at the difference, adding topotecan and a couple other chemotherapy agents to what our current standard of chemo care was. But it showed us some very interesting things. Excuse me. So for many, 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 many years, surgery was the mainstay of what we call local control, meaning what you do with the tumor. As you all probably know, Ewing sarcoma really is a systemic disease. So, if you have a Ewing sarcoma in your foot, and let's say you amputate the foot and you don't do anything else, it's almost certain that you're going to develop metastases somewhere outside of the foot. It is even when we just see a localized tumor, we know that these tumor cells are floating through the body. So we then, combined surgery with chemotherapy, and that did a lot better job of preventing things from popping up. So if you, did an amputation of the foot and then you gave chemotherapy, a lot of patients never had their disease come back. Radiation, was sort of introduced for tumors that you couldn't take out surgically, and that's been the bias for many years. We think of radiation as the backup plan to when you can't take it out surgery, and I think that attitude is changing. Now, if you can take something out safely with a little morbidity, and it's a Ewing sarcoma, I think, if this were my child, that's what I would do. The nice thing about surgery is that you avoid any risk of radiation toxicity and any risk of radiation-induced tumor, even though it may be very low. And then the second thing is when you take out that tumor, you can actually see how well your chemotherapy is working. So you'll see what they call necrosis, and sometimes it's 10%, sometimes it's 90%. You can basically see how well the chemotherapy is doing at attacking your tumor, and at that point, you can make adjustments. So, if you can do a small surgery or reasonable sized surgery and have an excellent functional outcome, all of us would say, go ahead, do the surgery. And these are some pictures of some late radiation toxicity. Just, I wanted to be fair and show the radiation when you get treated very young, can cause some problems. And so this is someone who was treated to their scapula when they were very young. And you can see the asymmetry in their muscle development, and they even still have some skin reaction. And then this is someone who was treated, I think, to their entire limb with radiation, or a very large portion of the bone when they were very young. And you can see that this leg just never developed the muscle bulk after that this one did through development. Now, I will say these are very, very old slides. These were slides from a talk that I gave when I was a resident, so some 15, 20 years ago. So the techniques that we use minimize this much more, but there are risks associated with radiation. But surgery can do the same thing. So, if you had done surgery on this scapular tumor, this woman wouldn't have been able to raise her arm above her head. She would have had sort of a dead arm. And, in a lot of these cases, the limb length and limb width discrepancies would be the same with surgery, because you have to basically take out a fair amount of tissue around this and, where these muscles attach to the bone. And so you can also have this with surgery. So the question is radiation equivalent to surgery if the morbidity of surgery is high? And so these on the left here were the sort of a combined analysis of local failure for the last 3 big European and American Ewing sarcoma studies. And what this shows is that if you got radiation after 13 weeks of chemotherapy to control your tumor, you had about a 15% chance of that tumor coming back. If you had surgery, you had about a 7% chance. And if you had surgery and radiation, if you had surgery, you had about a 4% chance. If you had surgery and radiation, you had about a 7% chance. The problem was that this was sort of in an era where we were cherry picking, again, all the best cases for surgery, and then radiation got stuck with everything that surgery didn't want to take out. So Dr. Ahmed looked at the most recent Ewing sarcoma study, and she found that actually there was no difference between definitive radiation, surgery and radiation, and surgery. So there was about almost an 8% local failure risk with definitive radiation. It was about 7% with surgery and radiation, and 5% with surgery alone. But when you look at the p-value, it's not statistically significant, meaning that there's a very good chance that there's no statistical, that this could be by random chance, and that if you did that study again, that this arm could, definitive radiation could be the winner and surgery could be the loser, but they would still be very close. So there was really no statistically significant difference in whatever modality you used to control your tumor on this study. And when we looked at it more in detail, you could see that, again, so local failure, I mean, it coming back right where the primary tumor was, so whether it was treated with surgery or radiation. And so if you break it down by site, the pelvis, which was always thought to be one of the toughest areas to treat, we only had about, a 9.2 versus 8.6 local failure rate with surgery versus radiation. So both of them actually did pretty well, and there was no statistically significant difference between them. In the extremity, there was surgery looked to be the clear winner, with only a 3% local failure risk versus a 12.5% local failure risk with radiation. Now, again, if you have an extremity tumor, you're almost always going to get surgery. The only ones that don't go to surgery who get definitive radiation are the big bad ones that are very extensive or have lymph nodes, or there's some reason. So I think, again, you can say that probably these were cherry picked, but surgery did have a statistically significant benefit in the extremity. In the axial skeleton, meaning like chest wall or pelvis, or outside of the pelvis, chest wall sort of area, or trunk, basically the local failure risks were exactly the same, and they were not statistically significant, meaning radiation did just as well as surgery. And in extraosseous, meaning soft tissue, non-bone origin tumors, definitive radiation looked to do significantly better than, or numerically better than surgery, but that number was trending towards close to statistically significant, but was not statistically significant. But this is much closer in terms of our local control numbers that radiation and surgery have had than any other study we've done in the past. And it's probably because our imaging techniques are getting better, our radiation delivery techniques are getting better, and there's a more egalitarian approach to choosing cases based on, what's going to have the least amount of impact to the patient in terms of morbidity, because our second cancer rates are going down and our targeting with radiation is going up. So and then the last point I wanted to make on this, which was an interesting observation, was when you looked at the distant failure, meaning how many patients had, after treatment, had something pop up, if you were treated to your leg, had something pop up in their lung or somewhere else in their bones or their lymph nodes. There was actually a statistically significant difference in distant failure between surgery and surgery plus radiation versus definitive radiation, with definitive radiation having less distant failure. Now, how does this make sense? Well, what we're thinking is that when you get definitive radiation, there's no break in your chemotherapy. You tone down the intensity of the chemotherapy a little bit, but you're not actually taking a break. Whereas if you get surgery, you're off chemotherapy for sometimes a month or more if there's wound healing problems. So we think that maybe that break with surgery may lead to some more, that break in chemotherapy can lead to chemo resistance and allowing distant metastatic disease to arise. We don't know this, it's just our hypothesis, but it was certainly an interesting observation that we had from the most recent study. So more and more people are coming around to using radiation definitively in Ewing sarcoma. And when we do that, we're going to lean more towards proton therapy for all the reasons we talked about. And the last thing I'll just mention quickly is that there was a study out of India by Siddhartha Laskar, who's a wonderful physician. And he did a dose escalation study looking at, now that he had protons, can he get to a higher dose safely? And so the dose that we've used in America and other places for many years is 55.8. He went up to 70.2 gray, which is a pretty big escalation. And what he found is that the local control rate was, about 25% better when you use the higher dose. It's something we all suspected. This was a randomized study in a big, national hospital. So we were all excited about this. The problem is that if you look at these numbers, and I told you that this was from our last COG study, they still had a 25% risk of local failure, even in the best performing arm. Our local failure is about 5, 6, 7%. So and this is at 55.8 gray. So at this dose in the US, you're still doing much better in terms of disease outcome than you are at the higher dose in this Indian series. Now, Dr. Laskar himself has sort of admitted that things in, this hospital don't always go as well as they would. There are chemotherapy shortages, there are delays in treatment. So, but I think all of us still, really do believe that the next improvement for radiation is escalating the dose. And off study, a lot of us go to a dose higher than 55.8. We're now at about 64 gray based on this study. Okay, so efficacy of modern radiation therapy looks comparable to surgery, which was not always the case. Surgery is still a great option if you can get it out and with very little morbidity. Let's not give radiation. Let's avoid the risk of a second cancer, and in some cases, bone growth inhibition. Hopefully I showed you that the second cancer risk was a lot lower than previously reported, and it was basically the same as chemotherapy. And it's best to discuss sort of these approaches in a multidisciplinary setting. So, moving on. So actually, I had one more topic. Do you want me to stop there, or Emily, or did you want to...
We have about 15 minutes left, and we have quite a few questions. So if this is a fast
I
chunk,
think I think we should do this one because this looks interesting to plot.
Okay.
So,
All right, I'll give
but
you
we gotta make it quick, like
I'll be done in 5 minutes and we'll have 10 minutes for questions because this is really interesting. So basically, Ewing sarcoma with a lot of metastatic disease, not just in the lungs, has been neglected for a very long time. And we sort of should be ashamed of ourselves that we as the pediatric population didn't think of this, but we really haven't made any improvement in metastatic sarcoma because we just keep changing the chemotherapies and none of them have worked. Right now, the 3-year event-free survival is about 40%. So I want you to remember that number. It's about 40%. And the 3-year overall survival is about 58%. And all we've done for the last 10 years is try to add new chemotherapies. We haven't done anything with radiation or surgery. So we didn't do this, but adult radiation oncologists in lung cancer and colon cancer started being really aggressive, treating every metastatic site they could see, and patients lived a lot longer. So for this study, where they used ablative doses to these metastatic sites, there was the 5-year overall survival rate was 42%. If you just treated them with palliative doses that just sort of were temporizing measures, the 5% overall survival rate was 18%. So this was a landmark study that really changed the way. It was called the Sabre Comet study, and it really changed the way we thought about things. So there was another study that looked in pediatrics and a bunch of different sarcomas, and it actually showed the same thing, that if you treated everything that you saw versus if you just treated 1 or 2 lesions that were painful, patients survived much longer. So my partner, Dr. Acharya, and one of our wonderful residents at Johns Hopkins said, hey, we've been treating really aggressively. We basically have embraced this. That trial came out a while ago. For the last 5 to 10 years, we treat ablative dose to everything that we can see. We're a really good test case for, does this make a difference? And so we had a cohort that had 40% rhabdomyosarcoma, 40% Ewings, and 20% other things. And basically, we looked at our patients, and lo and behold, when we treated everything that we could see to ablative doses, the 3-year overall survival was 74% versus 43% if we just treated things that were painful or we didn't go to aggressive dosing. So that's the overall survival. And then the progression-free survival meaning, did they have a new lesion? Did what we treated progress? Again, a huge difference. 72% didn't have any progression at 3 years versus only 20%, 26% didn't have any further progression after 3 years if we weren't as aggressive. So a huge, huge, huge difference. And then the other thing we found, which was repeated in the COG study, was if we treated every metastatic site that we saw to an ablative dose, your distant failure rate was only about 40%, meaning new metastases at 3 years was only about 40%. If we didn't treat everything, then 71% of those kids had new distant disease. So again, a giant difference in terms of how these kids did. So I won't dwell on it, but basically we were totally surprised by the stark difference in that. And then we tried to basically account for bias, meaning the kids who we were more aggressive with, were they doing better? Were they, did they have better outcomes? And that really didn't seem to be the case. It was just which families and which doctors were willing to come and get all the aggressive radiation. So we should really be more aggressive with our metastatic sarcomas, metastatic Ewing sarcomas, and we really shouldn't dismiss patients who have diffuse metastatic disease, and that we might not cure them all, but we can get them living a lot longer than any COG study with chemotherapy. So, all right, that was the speed version of that.
Wow, what a note to end on too. That was that was really
that was a good one.
Glad we did that last chunk. That was really cool and super important. So we did get a whole heap of questions. Several of these are those patient-specific questions and looking for medical advice. So you'll have to forgive us for the people that submitted those questions. We may not be able to get into details on that. So we're going to focus on the more broad questions that have come through. So after a tumor has been treated with radiation and the affected cells die, what happens to the tissue and bone? Does that change over time, and does it affect the structural strength?
Yeah, so that is a great question. I probably should have put some more of that in there. So radiation is really interesting. So radiation and chemotherapy, they kill DNA. So they don't kill cells. So basically what we do is those particles go in and they break up the DNA, and then those cells are functionally castrated. They can't make any more of themselves. So they sit there until they try to divide, and then they fall apart. Just like any dead cell in your body, cancer or non-cancer, your body's own immune system cleans it up and recycles it. So those macrophages come in and they kind of eat it up. And all your inflammatory cells come in and sort of do their thing and clean. Now, when you get toxicity from radiation, it's actually not because the radiation kills the normal cells. We kind of fractionate a little bit every day. And that's why radiation takes so long, so that those normal cells actually don't die. What happens is we create this inflammatory response in the area that we treat. And what your body does is, instead of laying down normal stretchy, muscle tissue or bone tissue or whatever, it lays down scar tissue, whether that's, in your lungs, in your bones, in your muscle, in your brain. And so if you're very young, you go from having a nice stretchy, or, at any age, but more so when you're young, you go from having nice stretchy tissue in there to scar tissue, and you don't get as much oxygen in there, and it doesn't grow as well. So it's actually the inflammatory reaction that radiation produces that really causes the long-term issues. You don't get as much blood flow, you don't have as much stretchy tissue, so that muscle doesn't grow as big compared to, the untreated side. Or, even in the brain, it's the same thing. There's a little more scar tissue, a little less blood flow, and that area is just, it's basically premature aging. That's what happens to us when we age. So it's that inflammatory reaction that kind of is in response to, that tissue, the tumor destruction in there, that really causes the side effects. It's not a direct impact of the radiation, if that makes sense.
All right. Thank you for that, Dr. Ladra. There's a whole host of questions, a lot of them case specific, surrounding whole lung proton radiation. Can you kind of just generally comment, what's the youngest patient population you're treating right now? Are you treating males?
So we do treat, so I've treated some males, but I actually think they do better with the conventional radiation, because, it's really the breast tissue that you can spare with protons that you can't do it with photons. And like I said, protons are very, so what I didn't add, because it would have taken too much time, is that I have a very, when I do the whole lung radiation, you have to be old enough to do breath hold. So, and by breath hold, I mean, it takes a really long time. You have to hold your breath in for like 30 seconds, and we turn the beam on, and then you exhale. And then you hold your breath for 30 seconds, we turn the beam on, you exhale. And it takes about an hour to treat, because I don't want that chest wall moving if I'm trying to come in from posteriorly and protect that chest tissue. So the patients that I treat are female patients with enough breast tissue to spare, to make an impact, who are old enough and, who can comply with sort of instructions to do the breath hold. So it's really like 12 to 20-year-old, female patients. That's who I really treat with whole lung. Now, I will say Mayo Clinic is treating everyone with proton whole lung now. And we actually have a project that we're doing right now comparing our male patients that we do with photons versus theirs that they do with protons, to see if we should be treating male patients too. But I personally think we actually get better dose distributions with the photon radiation for the male patients.
Thank you for that.
Does a local recurrence after radiation mean the radiation plan missed certain areas of the tumor, or the tumor was resistant to radiation? In such cases, how do you make decisions? Or are some tumors resistant to radiation?
Yeah, so that's a great question. So it's a very unsatisfying answer, but the short answer is we don't know. So like if if you look at your radiation plan and you're looking at 100 to 80% of the dose, and that tumor comes back right in the middle of that, then we say that it was radio resistant. If it comes back in that sort of 50 to 25% of the dose, then we say, hey, did we underestimate, where that tumor was, and did we actually, have a marginal miss? So that's sort of how we categorize things. Like if you call it a recurrence versus a marginal miss. Now, why do tumors come back right in the middle of high dose radiation? There's a couple theories. One, that there's some mutation in them that allows them to repair DNA mediated or radiation mediated DNA damage, that they've just got something specific, because every tumor is different. Every tumor has its own unique cluster of gene mutations, and some of them are better at repairing DNA damage. The other thing is that, for radiation, you really do have to saturate an area. And could one tumor cell have just gotten so lucky that it was in an area where these protons and photons or whatever were just zipping by, and it just, it just never got hit with a lethal double strand break, and is it just statistically bad luck? That's another theory that's been put forth. We really don't know. But I sort of think sometimes that does happen because I've seen things come back right in the middle of the radiation field that we treated. We treat with radiation again because there's not another option, and then they never come back. So you would think that if it was radio resistant, that retreating with radiation again wouldn't work. But sometimes it does. So.
All right, we got time for maybe one or two more questions. So I'm going to try to clip along here. Switching gears a little bit, and with regards to fraction size, are you using Proton for SBRT at all? Is that like a higher fraction on a daily dose, or is that not possible?
Some people are doing it. I'm very apprehensive to do that. So protons already, when we use them in conventional fractionation, have more bang for your buck in terms of normal tissue damage. They're better because they're treating less normal tissue, but the normal tissue that does get caught in the crossfire, I think suffers a little bit more normal tissue damage. And so when you up that by increasing the amount of dose per day, I've been very reluctant to do that. I know that there are other centers that are doing that, but I have a twofold concern. In one, we don't really have any long-term toxicity data. And two, with protons, I do worry about marginal misses because, if you gain a little water weight or lose weight because of chemotherapy, when you're doing these high dose treatments, or that tumor grows a little bit, and the time it takes you to plan your proton SBRT, which can sometimes take a long time, you could be missing things. So I'm not saying that it's not going to be an effective treatment, but I haven't seen compelling data yet to move my practice that way. So
okay.
And the kids do really great with photon SBRT. It's, one of the things I didn't have time to talk about is that we've been treating with photons for a lot longer. So the machines are actually better at delivering photons. So we have these machines that can spin and treat and spin and treat. Whereas with the protons, you have to move to one location, move to another location, move to another location. And that gives you less degrees of freedom to create these really conformal plans for small targets. So like I said, there's a lot of great uses for conventional radiation that's sometimes better than protons.
Excellent.
Thank you for that. Do you have another question, or we hit our time?
Yeah, I just wanted to, for the people who did ask patient-specific questions, they are important and you deserve answers. And we encourage you to talk to your oncologist and look at the National Ewing Sarcoma Tumor Board. There's information on it in the resources section of our website and instructions for how you can have your oncologist submit your case or your child's case to a group of experts who can take in kind of the whole picture and give some recommendations back to you. So it's a great resource that I think is underutilized. So check that out on the resources section of our website.
Well said, Emily. And then Dr. Ladra, is there a way for second opinions through your practice that patients can reach you, or what is that route?
Yeah, I think the Johns Hopkins Proton Center has an online patient resource form. So if there's something specific, they can reach out through that.
Okay, perfect. Well, with that, I think we're out of time. Congratulations. I think you broke the record for the most number of questions we've had in a Ewings U. So there'll probably be a lot more follow-up coming your way. But nevertheless, thank you for that fascinating presentation and discussion. And thank you for everything that you do for patients regardless of the sarcoma type with proton radiation. It seems like you're onto something truly novel and cutting edge. And so we thank you for that. Emily, thank you for being my co-host as always and helping moderate the discussion. And then to all our participants, thank you as well for being here with us today. Please remember to stay up to date and join us on future Ewings U. And the easiest way to do that is to go to our website, littlewarrior.org, and navigate to the Ewings U tab. And also follow us on Instagram and Facebook, as we always post about the next speaker that way. So that's it for now. Hopefully you found something useful in this episode. We'll see you next time. And in true Little Warrior fashion, I think we all know this, in the count of 3, we're going to do just a simple swords up and bring this session to a close. So 1, 2, 3.
Swords up.
Swords up, everybody. Thank you so much.
Great
We'll see you next time.
Thank you.
Bye now.